Hello. Today we are going to discuss about the problem in the benign prostatic hypertrophy and the drugs that are used for the treatment of this condition. Now here you can see that this is the urinary bladder, okay, and here over somewhere there is a urethral sphincter. This is the bladder trigone. This part is the prostatic urethra, and this is the prostate. Now normally what happens, there is a contraction of the smooth muscle of this bladder and relaxation of this part, and because of this there is a urinary flow. Okay. Now on the bladder trigone, on the prostatic urethra and the sphincter, the receptors that are present are alpha 1, and when the alpha 1 receptors are stimulated, there is a contraction of all these components, the trigone, urethra and sphincter. Okay, so what, there is a requirement for the urinary flow. For the urinary flow, there is a requirement of relaxation of this portion, and that's why there is a easier urinary outflow. Okay, now what is the problem? What is the problem in the benign prostatic hypertrophy? There is an enlargement of this prostate, and over a period of the time this prostate encroaches to the prostatic urethra, and that's why there is a difficulty in the urinary outflow. And there are two types of symptoms. One is the symptoms due to obstruction, symptoms due to obstruction. Okay, and which are these symptoms? Symptoms due to obstruction are, there is increased straining at the maturation, narrowing of the urinary stream, and the person will feel that some amount of the residual urine is there. These are the symptoms of the obstruction. Okay, and while there are another type of the symptoms, these are also known as the irritative symptoms. Irritative symptoms, these are nocturia, increased urination at the night, dysuria, painful, and urgency. These are the two type of symptoms. Okay. Now, how to manage this? For that, there are two components. If you just look at this, there are two components. One is the component that is a static component. Static means there is a gradual progression in the size of the prostate. Okay, and the another thing is the, here you can see this dynamic component. Dynamic component. Dynamic component means the tone of the sphincter, trigone, prostatic urethra, that will impair the urinary outflow. Now, how you can act on the dynamic component and how you can act on the static component, and which are the other therapeutic measures in the static component. In the static component, we have to work on the prostate size. We have to reduce the size of the prostate. Reduce the size of prostate. Okay. While on the dynamic component, we have we have to relax. We have to relax these portions. Okay, strigon, prostatic urethra, sphincter, we have to relax this part. And as I have told you, the alpha 1 receptor is responsible for the contraction. So for the dynamic component, the requirement is alpha 1 blockers. Okay, alpha 1 blockers. So alpha 1 blockers, they primarily act on the dynamic component. Now as you can immediately see that the moment you give the alpha 1 blocker, within weeks you will find there is a improvement in the obstructive symptoms, and these symptoms, relief of the symptoms starts within week. Okay, but at the same time one can see that I just draw the figure again over here. That as the problem is with the prostatic size, and we are targeting this sphincter. Okay, and that's why the size of the prostate, until and unless we are not affecting on the size of the prostate, the relief of the symptoms, that will be short-lived and it is not the permanent solution. Okay, but for the immediate relief, the alpha 1 blockers are helpful. Okay, now which are the alpha 1 blockers? The alpha 1 blockers, these are the prototype agent is prazosin, another is terazosin, then doxazosin. Now before going into further, that the prazosin, it is a selective alpha 1 blocker, that is fine. But again in the alpha 1 there are three subtypes: alpha 1a, sorry, alpha 1a, alpha 1b and alpha 1d. Now you have to remember like this: the B for blood vessel, B for blood vessels. Okay, and majority of the, you all know that the alpha 1 receptors that are present on the peripheral blood vessels, and when these receptors are stimulated, there is a vasoconstriction. So whenever you are giving alpha 1 blocker, there will be vasodilatation and all the related adverse effects are there, which are actually not required in case of the BPH. So all the additional vascular adverse effects are seen with the prazosin. Okay, and the most problematic is, as there is a reduction in the peripheral vascular resistance, there is a immediately shunting of the blood into the peripheral system. There is a first dose hypotension, and that's why for whatsoever the indication, whenever you are prescribing prazosin, always instruct the patient to take this drug at a bedtime. Always start with a low dose, 0.5 milligram. Advise patient to take the drug in the bed only, in the sitting position, then gradually increases the dose from 1 milligram to 5 milligram. And the another problem with the prazosin is that it is a short duration of action. So you have to give this drug. You have to give this drug twice a day, and all the side effects, all the vascular side effects. Then there is another side effect, that retrograde ejaculation is there, impairment of ejaculation is there, nasal stuffiness, headache, all these side effects are there. So these side effects, okay, now in many textbooks, these receptors are shown. Don't confuse with this. These are written in a capital letter also. So alpha 1A, B and D. Okay. Now, if if you can selectively block the alpha 1A receptor without affecting the alpha 1B receptor, then you will achieve your target, because alpha 1A receptors, these are present on the bladder neck, trigone, sphincter, everything. So what we require is the selective blockage of the alpha 1A receptor without having effect on the alpha 1B receptor. And these type of the agents, selective alpha 1A blocker, are also known as a uroselective alpha blocker. Uroselective alpha blocker. And which are the uroselective alpha blocker? These are the tamsulosin. Primarily, the tamsulosin is used for this indication. Another advantage is tamsulosin, the single daily dose is sufficient. The vascular side effect is also not seen, and its dose ranges from 0.4 milligram to 0.8 milligram. Okay, so this is all about the selection of alpha blocker. Now, as I told you, the alpha blockers, they are not acting on the prostatic size that we require, but there are two alpha blockers which is having a apoptosis promoting effect on the prostate, and these are terazosin, terazosin and doxazosin. So if someone asks you that which alpha blockers are having apoptosis promoting effect, your answer should be terazosin and doxazosin. Which is a uroselective alpha blocker, then your answer should be tamsulosin. Okay. Now the second drug which primarily targets the prostatic size. Okay. Now for the growth of the prostate, what is required? The required is dihydrotestosterone. It is the active component of testosterone. Now from where the dihydrotestosterone is produced? That is from testosterone. Which enzyme is required for this? There is a requirement of 5-alpha reductase. So when you block this enzyme, the conversion is not going to occur. There is a blockage of this conversion. And because of this, the dihydrotestosterone mediated increase in the size of the prostate, it is going to be affected, and that's why it has been seen that if you inhibit this enzyme with any drug for a period of 6 to 12 months, there is a gradual reduction in the size of prostate, and the agents that are used is 5-alpha reductase inhibitors, and these agents are finasteride and finasteride and dutasteride. These are 5-alpha reductase inhibitor. They reduces the size of the prostate, but remember, these agents require at least 6 months. Now you just remember in the comparison, this will be helpful. Okay, now the 5-alpha reductase inhibitor, they reduces the prostatic size. Okay, they primarily affect the static component. while the alpha blocker affect the dynamic component. Okay, here in the alpha blocker effect is seen in weeks. Here it is required minimum 6 months. Here the effect is in the alpha blocker, the effect is short lived. Here the effect is long lived. So ideally there should be combination of alpha blocker, especially the alpha 1A selective blocker, and plus 5 alpha reductase inhibitor are to be given. Okay, so this is all about the pharmacotherapy of benign prostatic hypertrophy. Thank you.